Presenter is Farzan Sasahangohar, who is the Assistant Professor of Industrial Systems and Engineering and Environmental and Occupational Health at Texas A&M University. Farzan, I'll hand it over to you.
Thank you so much. Good afternoon, everyone. Today I'm going to share some of our preliminary findings from our ongoing research at Texas A&M in collaboration with AHA on this new hypertension mobile coaching program or care plan. The work is supported by National Science Foundation Engineering Research Center called Precise Advanced Technologies and Health Systems for Underserved Populations, or PATS-UP. We talked today, and some of our speakers talked today about the value of coaching. We know it's an emerging field in hypertension and all chronic diseases, shown a lot of promise. Recent systematic reviews were published evaluating the use of a combination of some sort of coaching and mobile health in self-management of hypertension. For example, Liu et al., and I have the citation on my slide, they reviewed 11 randomized control trials, all of which included some form of human interaction and some sort of technological intervention. Now, most of these interventions showed promise, but most of these studies, actually all of them, as far as we know, involve human health coaching. So a human health coach was used in combination of series of interventions. Very rarely we see application of automated digital health coaching to hypertension care, which is much more scalable. Think about a pandemic situation and how scalable it would be if you had more intelligent type of coaching. It seems to be, this is a general research gap. We also did a scoping review recently where we showed that telehealth combined with health coaching is very effective at improving quality of care. However, there's still very limited empirical evidence suggesting that this combination of mobile health and intelligent coaching systems will produce similar effects for hypertension. So to address this gap, the purpose of our research was to determine if using a self-measured blood pressure SMBP program combined with mobile health coaching would have any sort of positive impact on clinical outcomes and user engagement. We partnered with the AHA to design a novel 30-day health coaching plan based on the AHA 12-week hypertension care plan. This HyperCoach, the platform we created, included daily physiological monitoring of blood pressure, heart rate, and weight. And that information was pushed automatically daily into this health coaching platform using the smartphone app. The content we delivered through this care plan included daily persuasive reminders to perform blood pressure and weight measurements, the establishment of goals, also a lot of educational content that was vetted through AHA in the form of short videos and 1 to 2 page brochures. We also had weekly multiple choice quizzes on the educational material and weekly progress report. The videos and brochures had a lot of content on education on BP monitoring, hypertension, ways to self-improve, self-manage, and maintain a healthy lifestyle for blood pressure and hypertension. But there was no specific communication between the patient and any sort of human healthcare provider. Last spring, we conducted a case-controlled longitudinal home study, a pilot study, to evaluate this 30-day hypertension mobile health coaching program. The intervention for the study consisted of that mobile application, HyperCoach, that I was talking about, that delivered this AHA-approved 30-day hypertension coaching plan, and 2 devices, a Bluetooth-enabled weight scale and a Bluetooth-enabled blood pressure cuff. The daily measurements would automatically pop up in this application. We made it a lot more effortless, and a lot of usability engineering and human factors engineering went into design and development of this product. Study had two phases. During the health awareness phase of the first 30 days, participants only received instructions to do measurements, daily measurements for blood pressure, heart rate, and weight. And they also had access to their trends. But in the second 30 days, which we called health coaching phase, they were provided with this full set of information, and we provided coaching material, reminders, goals in addition to those daily measurements. This is just a very short overview of HyperCoach. I wish we could do justice to this app and platform, but this is a mobile application we developed to deliver that coaching content. We went through various iterations of usability testing with patients and intended users and providers. The main focus was providing a calendar of activities, list of daily tasks, and overview widgets for daily blood pressure, heart rate, weight, and step values, as well as averages and trends. Our participants had access to this My Plan Calendar widget, where they could see in any given day what tasks are there in terms of educational and coaching content, but also daily measurement. This widget displayed, if they've completed those tasks on a calendar view, they could see what they're lagging for, and what kind of incomplete tasks are there. We also had a dashboard display, which provided more information, more big picture, high-level type of information about blood pressure, heart rate, weight, step counts. You see green check marks kind of showed them if they completed some of those tasks, they would get reminders if they haven't. And then you see more of these kind of widgets. This one is an example of a blood pressure widget. It showed the range of BP readings over the previous 60 days. It was very interactive. They could play around with it. It showed the trend for last 7 days. It was color-coded as normal, elevated, stage 1, stage 2. And it had a green horizontal line, 2 green horizontal lines to show AHA recommended BP goals. Similar widgets were provided for heart rate, weight, and daily steps. Now, we recruited 35 participants from our large Texas A&M community via listserv, post, and snowballing. The inclusion criteria included taking hypertension medication, and participants' primary diagnosis had to be hypertension, and they excluded those with resistance hypertension diagnosis and more than 2 comorbidities based on the Charleston Index. We measured the average changes in systolic and diastolic blood pressure, changes in hypertension classification over this period, and average changes in weight, BMI, so on and so forth. We also conducted an SF-36 quality of life questionnaire before and after the study and midpoint, and evaluated changes in health literacy, health beliefs, and monitored the levels of engagement in real time. So in this short presentation, unfortunately, I can't just show you all the results we obtained, but I'm going to focus on just the very high level, most important results related to health outcomes. This shows you the mean systolic and mean diastolic blood pressure reduction. We measured that at baseline, mid-study, and post-study. We compared those. Participants' mean SBP value did not change during the health awareness phase, but showed a statistically significant decrease from 136 to 130 during the health coaching phase with a medium effect size. The DBP kind of had the same impact. We didn't see a significant change during the health awareness phase, but it showed a significant decrease from 85 to 81 during the health coaching phase with a medium effect size. We also noticed a marginally significant decrease in BMI during that health coaching phase. The mean value of health-related quality of life scores, which is SF-36, showed that from baseline to mid-study to post-study, participants' mean HRQL score showed a non-significant increase during the health awareness phase, but showed a significant increase from mid to post-study. We also looked at the participant general knowledge of hypertension at baseline, mid-study, and post-study. These were compared using a 10-question multiple choice quiz developed in consultation with the AHA And the participants' mean score for knowledge of hypertension showed an insignificant increase during the health awareness phase and a significant increase during that health coaching phase with a very large effect size. We used constructs from theory of planned behavior and health beliefs model to investigate the effects of intention to use these sort of interventions, mobile health coaching interventions in particular. And these constructs were measured at the beginning of the study and during the transition to that health coaching phase. We use structural equation modeling to conduct this sort of PATS analysis that shows the impact of these constructs on each other and how they eventually predict intention. Not going through details of this analysis, just to show you our emphasis on personality traits and health beliefs, but there are some significant relationships and predictors of intention, including perceived health threats, past experience, and indirectly through resistance to change. So just to wrap up, we looked at all these analysis of variances and interaction effects, and we noticed that improving awareness of blood pressure alone by showing them those values daily is helpful, but it's not enough for a significant change in health-related behaviors, except for hypertensive stage 2. Those improve significantly even during the awareness stage. And we saw a lot of promise in providing health coaching information in conjunction with that SMBP program. And we plan to do a lot more than that. We're going to extend this three months program into a 12-week coaching program, and we're planning on a longitudinal study plan for spring 2022. I'd like to thank Pat Dunn and the AHA for the support and this impactful research. I'll be happy to answer questions, and I'll be happy to partner with any of you who are interested in using this platform, HyperCoach platform, to do research for your own purposes. Thank you so much.
Great. Thank you so much, Farzan. It looks like we have a couple questions for you. The first, I think, is top of mind when we hear about all this great collection of data is, are patients able to send this data to different healthcare providers and perhaps via a FHIR application or connection to the EMR EHR?
Of course they can. So the platform we developed has a HIPAA compliant component to it. The data is batched and transferred into our AWS server in real time. So every time there's a measurement, the data goes automatically to our HIPAA compliant server. With partnerships with clinicians, that could be easily integrated into their system so they could have access to that data.
Great. The next question is, have you considered pairing what you're doing here with other great innovators in the space, perhaps with one of your fellow innovators on this panel discussion? And if so, could you just talk a little bit about the partnerships that you're doing?
Absolutely. I would love to. And that's why we're here. I think that's why AHA, part of the mission is to connect us and make sure we have some convergence going on to address and tackle these very important societal issues. On our partnership, in our center, PATSUP, the NSF PATSUP, we have various industry partners. It's actually a very large advisory board, industry advisory board we're having, including AHA and Pat Dunn included, where we try to find convergence, use their feedback to drive research and feed them with this research to make sure our research has practical implications. So I invite anybody who's interested to visit Pat's Up website. I think it's called patsup.tamu.edu or my website. There's a link in the ACE Lab website. But anybody else who's interested in collaborating, I would love to hear from you to be able to accomplish this together. I'm amazed by the research and the work my fellow panelists are doing, so I'd love to connect with them as well.
Wonderful. Thank you so much, Farzan, for sharing all this information with us. And just monitor the chat as questions are still coming in.
Absolutely.
Wonderful. Our next